Hello, everyone, and welcome to this year's virtual Lighting the Way conference. I'm so glad you could join us and hope that you're finding this format to be reasonable for our busy lifestyles and what we found ourselves in through this COVID experience. So my name is Brittany Schmidt, and this session is entitled Characteristics and Beginning Introductions for individuals with autism spectrum disorder. It's going to be focused primarily on characteristics for those who are new to the field and also new to the diagnosis. If you're a family member or grandparent or a new professional or a seasoned professional who hasn't had an individual with autism that they have provided support and education for. And I'm just noticing in the background is what my family looked like about 30 years ago, 28 years ago. So that's always awesome. So anyway, thank you for joining the conference. And again, I hope that you're finding good information from what you've been hearing. So let's get started. This presentation should be about an hour or so, so you can plan accordingly. I'm just going to share my screen so you can see the slides. There we go. All right. So introduction, here we go. Again, my name is Brittany Schmidt. My contact information is on this slide, and it will be again on the last slide. Feel free to give me a call or email or text or whatever anytime if you have questions about the contents of this presentation or other questions you might have. All right, so just generally speaking, what is autism or autism spectrum disorder? It is a lifelong developmental disability. It's 4-to-1 boys to girls. It does occur in all racial and ethnic and socioeconomic groups. So if it's lifelong, people are born with it and people pass away with it. It does not contribute to earlier death in its individual diagnosis. There are other things that might do that. However, seizure disorder, tuberous sclerosis, etc. But autism itself, it does not impact longevity. Leo Kanner is a psychiatrist that first coined the term autism in 1943, and he was working with a group of, I think it was 12 young men, and he noticed similar characteristics between these individuals, and of course, social differences, communication differences, and repetitive behaviors. And the first part of the word autism is aut, so to oneself or within oneself. So that is where autism came from. And Leo Kanner also had a South Dakota connection in that he was a psychiatrist down at the Human Services Agency in Yankton. And there's a building that's called the Kanner Building. If you are on the way to the lake or whatever, if you look to the right, you'll be able to see it. Incidence strictly defined is 1 in 54 births, and that is as of 2020 from the Centers for Disease Control. That means 1 in 34 boys are diagnosed with autism and 1 in 144 girls. The cost that we incur for the care of individuals with autism spectrum disorder can be reduced by 2/3 with both early diagnosis and intensive intervention. So I always say there's no harm in referral, but there is harm in waiting. So we want to make sure that we're really getting as early identification as possible. And when I say harm in waiting, it really is in terms of behavior and communication development, and then also patterns of behavior as it applies to eating and toileting and those kinds of things, self-care. So that's where that is at. What causes it? We don't really know, although the best hypotheses or the most researched hypotheses look at it being a genetic etiology that cause both neurologic and or brain abnormalities or differences. It's not that we can see these on MRI, but we know that the neurologic presentation is very strong in individuals with autism spectrum disorder. It can't be all genetic though, because individuals who have identical twins, both twins don't always have autism. So if one has autism and they're identical twins, if it was a purely genetic cause, then both would have autism diagnoses, but that's not always the case. If you have a sibling, for a person with autism who's diagnosed with autism, and then that person has a sibling who has autism, so two people in a family, the likelihood of having a third sibling raises significantly. It's, and I think I have the numbers on another slide, but it's one person with autism, it's like 2 to 12% risk of having another sibling. But if you have two siblings with autism and then a third baby, the incidence jumps way up. It's like 35 to 70%. But the challenge with that is many times characteristics of autism, we're looking at that at about that 2.5, 3-year-old range when, although we can diagnose it earlier, so don't forget that, but when, language and communication is such a big part of children's development and play skills and, flexibility and problem solving and emotional regulation. So many times when a child is diagnosed with autism in that 2.5, 3-year-old range, the family might already be pregnant with a second baby. So not that there's a huge increased risk. However, it is a stressor for sure to be going through that process when you're also expecting another baby. So about 10% of people with autism also have a genetic or chromosomal abnormality or condition such as Fragile X or tuberous sclerosis, excuse me. And then also children born to older parents are at a higher risk. So then, in order to diagnose autism, both in the medical community and also in South Dakota in the education community, we utilize the DSM, the Diagnostic Statistical Manual, 5th edition criterion. And the DSM-5 was was initiated in 2013. Of course, prior to that, we were DSM-4. So how they changed it was from 1, 2, 3, and 4, and then now 5, is that they accounted for the cognitive differences all within these first 3 criterion. And so what used to be considered a autism as being 5 different diagnoses, they put those together under autism spectrum disorder and then accounted for the cognitive differences from individuals who are more have more intellectual disability and less intellectual disability and more or less social differences or more or less communication differences. And they put those types of individuals into one criterion list, which is social communication and social interaction. So it has to be across multiple contexts, and you have to meet all 3 now. So the first one is deficits in social emotional reciprocity. So that's that give and take, back and forth. Even if language isn't involved, that social exchange and that social recognition that other people have thoughts, feelings, and ideas. And then you put on top of it language. So how we have conversations, how we recognize that other people are having a thought about us, recognize tone of voice and what that might look like or mean to us as we're communicating. Back and forth in terms of initiating. So how do I get into a conversation? How do I get my needs met? How do I approach another person, either non-verbally or verbally, in a way that gives them a good thought? So that's number 1. Number 2 is nonverbal communicative behaviors used for social interaction. And number 3, we kind of talked about that already. And number 3 is deficits in developing and maintaining and also understanding relationships, from adjusting behavior to recognizing the difference between a friend and a classmate, understanding understanding how different levels of relationship work as we're getting towards that dating and possibly marriage age. All of that plays into that, all the way to a total lack of absence of interest in peers, or really, demonstrating that it's not that important to them. I'm not saying it isn't important, but that's the message they might send to others. So an individual who later gets diagnosed with autism spectrum disorder would have to meet all three of these. All right, and then I always like to put this up because I'm a speech language pathologist, but just because I can talk, so a lot of times we have individuals who are verbal or even highly verbal, doesn't mean that I understand. And this can range the gamut in individuals with autism. And later we'll talk about the incidence of individuals who are verbal versus nonverbal or less verbal or idiosyncratically verbal. So this can mean I might have a whole bunch of language because I'm using immediate echolalia, so kind of repeating back what I've just heard. But when asked to follow a one-step direction, I can't do it. Or I really struggle to do it. Or I might use language that sounds quite precocious and quite high vocabulary. So it's our nature, if someone is using higher vocabulary, to also match that verbal output. So how they're talking, we try to match that level of vocabulary. Well, and then it becomes pretty evident very quickly that that's not their understanding level, even though it's their usage level. And we'll talk about some of the indicators of that in a little bit. And then the next criterion, so the first criterion was social communication with 3 criterion under it, and we had to meet all 3 of those. The next one is restricted and repetitive behaviors, patterns of interest or activities. And there's 4 criterion in this area, but we only have to meet 2 of them to have an autism spectrum disorder. If we meet more, that's okay, but we have to have at least 2 of them to say that this individual meets criterion for autism spectrum. Okay, so the first one is stereotyping repetitive motor movements. And this is what a lot of people think of when they think about autism, although I can tell you that a lot of the people that I come in contact with, this isn't the first thing that comes to mind. So don't think that if a person isn't, flapping their hands or, doing kind of whole body movements or rocking or lining up objects or, organizing them by color, that they, if they're not doing that, it doesn't mean that they don't have autism. It just means that's one of the criteria that they don't meet. The other thing that falls in here that people sometimes forget about is repetitive language or idiosyncratic phrases. So saying things in a way that you kind of know what they're saying, but it's just not quite right. So for example, I had a young man who every single time he answered the phone, it was, "Hello, is your pizza in the freezer?" And what that came from was delayed echolalia. So he had walked into a room, into the kitchen, and his mom just happened to pick up the phone, and she said, "Hello." And then to the brother that was standing behind the son with autism, she said, "Your pizza's in the freezer." So it was chunked as one piece of language. So when this young man would answer the phone, he'd say, "Hello, is your pizza or your pizza's in the freezer? Hello, your pizza's in the freezer." So it's close, but not quite, right? And so that's an example of idiosyncratic phrase and also delayed echolalia. Okay, this is also like flipping of objects. I have, there's, depending on cognitive level, depending on language level, the more intellectual impairment there is typically, or the more difficulty with communication, I see this criterion being more impactful to the individual. Insistence on sameness, inflexible adherence to routines or ritualized patterns of behavior. This is also kind of the rigidity criterion. So if people have a high need to do things the way they see being done, bedtime, significant issues with bedtime routines, significant issues with kind of rigid thinking. Sometimes anxiety comes into this criterion as well. So you have to you have to know the difference between an anxiety-based response and a inflexible adherence to routine response and be able to differentially look at those two presentations. The third one is fixated interests that are abnormal in intensity or focus. So these are the things that they know a lot about, or they are attached to, or they might carry around an object that is, and it might not be the same object, but I call it a transition object. So like when they're going from, like from mom's house to grandma's house, or school to work, or whatever, they have, school to home, that was a bad example. They might have something in their hand at all time. It could be knowing everything there is to know about suspension bridges. It could be, a very intense interest in unusual creatures, or something. And typically we see differences between males and females in what they're interested in. So we'll talk more about that later. And the fourth one is the sensory processing, or sensory difference criterion. So hyper, so meaning too much reactivity, or hypo, meaning too little reactivity to sensory input, or unusual interest in sensory aspects. So like I have some kids who, when the light is on, they will look at the light and filter that light through their fingers. So that could be a repetitive motor movement, but it can also be a sensory seeking activity as well, or characteristic as well. Unusual differences for pain and temperature, some different responses to sounds or textures. So, but it has to be, this isn't standalone. There's plenty of people, most people have differences in their sensory systems, but it's the extent to which it impacts their functioning. So, and I'm not going to talk a lot about this one because although it's very important and very impactful when we start talking about interventions, it's not a standalone criterion. So there are people who don't have autism who have sensory processing disorder or difference. Okay, so it's not, it has to be in conjunction with the 3 social communication, and then at least one more of the restricted and repetitive behaviors. All right, I feel like I should ask questions right now, but no one to ask questions to. This was a 4-year-old boy who, at the time of this drawing, he was diagnosed with Asperger's syndrome. He would now meet criterion for autism spectrum disorder. He was diagnosed with Asperger's because he had no delay in communication. He had significant sensory differences, significant difficulty with social communication, was precociously verbal, and his area of interest was battles of, it was World War II, but particularly battles of World War II. And if you kind of take a look at the details in this picture, we've got the little guy down at the bottom here with some sort of bayonet looking gun. And, there's the treads on the tank, and the dispersal of the ammunition out the front of the gunner on the tank. And anyway, so a lot of detail. This is also a young man who couldn't write his name, or found it horrible to write his name. Anything that was kind of an academic demand, coloring, painting, those kinds of things made absolutely no sense to this young man's brain. So, but yet he was able to draw this very, very detailed picture. And so one of the things that happens here is it looks like noncompliance. It looks like laziness. It looks like kind of naughty, right? But that is not what was going on with this young man. He just had very different fine motor tolerances based on motivation for the activity that was happening. And this little guy this is insistence on sameness, rigid routines. He had interest in both superheroes and animals. So you can see them all lined up here. So to me, I'm not sure if this is right, but to me, it kind of goes elephants, tigers, whatever these small little creatures are. And then also a little bit by color, but it probably is more by category of animal. And then these are this type of superhero, and this is this type of superhero. And I used to have several ones where there's lots of Lego structures being stacked, those kinds of things. It's hard to show cognitive areas of interest in a PowerPoint, but I've had lots of individuals who know everything about insane creatures, or know everything about basketball stats or baseball or whatever. It doesn't really matter the area of interest. It just matters on how impactful it is to that individual's life and well-being. So some early indicators that we look at. So, we can diagnose autism as young as 9 months, excuse me. Many children are diagnosed between that third and fourth birthday, like I said before, and that's pretty late, so we have a lot of play and language and emotional regulation development that happens in that first 3 years of life. So we really want to be on top of it with well baby visits and understanding what typical and atypical development might look like. Pediatricians are required to screen for autism prior to 18 months. Okay, so if you're taking your child to a pediatrician, they should, as part of the 18-month or before well baby check, have a autism screening. If you're taking your child to a nurse practitioner or a family practice person or general medicine type person, that person doesn't necessarily have to. It shouldn't say that they don't, but they're not required to do that as being a pediatrician. So you should be asking your child's doctor about performing a developmental screening. At any point, if anyone has any or concern about a child's development, birth to 3, through each state has a birth to 3 program, and that can be accessed right through your local school district. So that's honestly one of the best ways. So you want to have, the things that you're concerned about, or the things your pediatrician or others are concerned about, and they'll come out and do a screening, not necessarily for just autism, but just overall development. But if you have a concern about autism, definitely start either with your school district or your physician and ask what's the best in your situation. 5 behaviors that warrant further evaluation are no babbling or cooing by 12 months, is not gesturing, so point, wave, head nod, head shake, and then also grasping, pulling at objects, does not say 2-word phrases by age 2. And this is, to me, that's a really big indicator. By about 18 months, well, probably 20 to 24 months, they should be saying things like my bottle, no, daddy, that kind of stuff. And if they're not doing that, that's a pretty big indicator that that there's at least receptive expressive language delay or expressive language delay, but there also might be some concerns with an autism spectrum disorder. Any loss of skill in language and social at any age, and then is not looking at objects when another person is pointing to them. That's called joint attention. So, like if I see that it starts snowing and I go, and I look and I point out the window, that baby or that little kid under age 2 under age 1 should go and then look at whatever it is, follow your point, and then look back at you like, what is it? Or, I see it. And so you share that social engagement, and then you look back at the object or the thing of interest. That's a 3-point gaze shift. And even without language, babies, children, little tiny kids, toddlers have joint attention if they don't have autism. So that's a really good indicator. Any child demonstrating those concerns, those 5 behaviors should be seen by a multidisciplinary team. And the multidisciplinary is really important. So that means a psychologist, an educator, a speech language pathologist, probably an occupational therapist, sometimes a physical therapist. And of course, we're always ruling out any audiologic or hearing health issues that might be impacting that child's ability to gain language purposefully. This Learn the Signs, Act Early is a really good website for looking at just early signs and kind of tracking developmental progress. Really good information on that website. Okay, in addition to those core areas, social communication and repetitive behaviors, we also see intellectual disability. And I'm going to talk a little bit more about that in a second. Splinter skills, so some things that are easier for the child and some things that are, or adult, individual, and things that are more difficult for the individual, kind of uneven profile. If we typically developing children kind of have an even profile and they just develop at a kind of an upward progression, kids with a developmental delay still have a pretty even profile, although the rate of acquisition of skills is probably at a slower or more depressed rate than a typically developing child. children who have an autism spectrum disorder have a very splintered profile. So gross motor might be a skill area, fine motor might, high skill area, fine motor might be a lesser skill or a more complex activity for that individual. Reading might be very high, math might be challenging, whatever it is, it's just a very uneven profile. If we look at these, hyperactivity, short attention span, impulsivity, those three are frequently looked at as attention deficit hyperactivity disorder or hyperactivity disorder. And many times families will see this because it's really challenging to work with or be in a home with or whatever, an individual who has these three things. And so they're thinking, oh, it must be ADHD. But if you're looking at those three things together, it can also be an indication that they might be struggling with some social differences. And why are they struggling with the social differences? So keeping in mind that ADHD isn't always just ADHD. Temper tantrums or extremes in behavior that is almost always tied to both communication and or sensory differences. So pretty big extremes could be because all of a sudden, you touch my arm and I'm having challenge with that. Or, mom put the green beans too close to the mac and cheese, or, the wrong socks were bought, or the temperature is not right. And so we have those extremes in behavior. We also have extremes in behavior when communication is impacted. So we have a child with significant expressive communication differences, and it's much easier to scream, hit, bite, kick than it is or is maybe even available to them to say no thank you. I call it saying no thank you very much when kids have those extremes in behavior. So eating abnormalities, usually too little, not too much. Although I do have a lot of people, a lot of kids, a lot of adults who will do nighttime eating for a preferred food, like whole bags of Cool Ranch Doritos gone, whole pounds of bacon gone, that kind of stuff. Sleep disorders, usually too little, not too much, and lack of fear. So I cannot tell you the number of times I've been around kids and they're all of a sudden doing something and the mom is cool as a cucumber, or the dad is cool as a cucumber, and I'm freaking out because the child is doing something that I would consider a dangerous activity. Like swimming to the bottom of the pool when they're little, or staying underwater for extended periods of time, or climbing up on top of the cupboards, like when there's time or there's space between the ceiling and the cupboard, that kind of thing. So the variability of individuals, and this changes occasionally. So I pulled this on May 11th of this year from the Centers for Disease Control, Centers for Disease Control, CDC. So back we talked about this a little bit before, but studies have shown that among identical twins, if one of those twins has autism spectrum disorder, then the other will be affected about 36 to 95% of the time. So it's a very big, so a third to 2/3 of the time in identical twins. If one child has ASD, then the other is affected about 1 to 31% of the time. Again, a very high rate of variability in what we know about this disorder or this ability. Parents who have a child with ASD have a 2 to 18% chance of having a second child with ASD. I already said this one, about 10% of the time are also identified as having Down syndrome, Fragile X, tuberous sclerosis, or other genetic abnormality. And the presentation of autism in each of those other genetic concern or genetic situations can be different. So like an individual who presents with both Down syndrome and autism spectrum disorder can present socially different, and also from a motor standpoint differently, just because of the genetic components. So you have to understand both of those. Almost half, about 44%, have average to above average intellectual ability. Okay. When I first started in this field, we used to say 75-25. So 75% of the individuals had some level of intellectual disability. So, and then we called it mental retardation, and 25% didn't. And we're realizing, primarily because more individuals who have higher cognitive levels or average IQ are being better identified, but also because our research has gotten better at looking about how individuals with autism, how we can best look at their intellectual ability and where their strengths are and things like that. So we're at about 44% now. Children born to older parents are at a higher risk. ASD commonly co-occurs with other developmental, psychiatric, so anxiety, depression, oppositional defiant disorder, obsessive compulsive disorder, neurologic, so tuberous sclerosis, those kinds of things, chromosomal, and genetic diagnoses. So it's not a one or other kind of deal. They frequently co-occur. And the co-occurrence of one or more psychiatric diagnoses is 10%. Okay, so it would be very, in my practice, it's higher than that. It's probably more at about 80%. I see a lot of individuals who are higher functioning, meaning they have IQs that are at or above, significantly above average. Most of them have IQs that are bigger than mine. So I have but they also have much higher rates of anxiety, depression, a little bit of paranoia, but anxiety and depression for sure. Okay, what used to be Asperger's syndrome, we're looking more at that gestalt processing, that big picture thinking being difficulty, significant difficulties with executive functioning, so organization, planning, time management, use of time, understanding how time is utilized in a functional way, and then theory of mind, knowing that other people have thoughts, feelings, and ideas. That's the kind of the crux of that that type of learner. And people with Asperger's syndrome did not have any diagnosed intellectual disability, and they may or may not have difficulties with daily living skills. I find that most of the people that I work with do have significant daily living differences. Their skill levels are quite impaired. So when we talked about before the interest areas, so under repetitive behaviors, patterns of interest, males and females typically do have different interest areas. Males being more factual and analytical, a lot of history, a lot of science, they're reading things about science fiction and adventure. I have a lot of kids who are males that really like, what is that author, Riordan? I can't think of it right now, like Airbender, that kind of stuff. Of course, Star Wars and all that is real big. Visual, so video games, computer, TVs, movies, Roblox, that kind of stuff. Roblox, Minecraft, all the ones that are kind of different too. And then mechanical things, how things work, how they go together, how you take them apart, like the inner workings, those kinds of things are of interest. Females, you see, I almost always have animals as an area of interest. Reading, but more like about classic literature, classic poetry, Edgar Allan Poe, Emily Dickinson, those kinds of things, Catcher in the Rye, Jane Eyre, those things. Arts, dance, drama, and music, not necessarily that they may be participating in those, because frequently we would have frequently there's co-occurring gross motor differences. But musically, I have a lot of females that are very interested in different genres of music, and also may be participating in music. They're very factual, but it's things that are like art history, history of their genealogy. A lot of females are into that right now. History of, what is that called? Like not architecture, but I suppose autobiographies, that kind of thing, personal history, and very precise. You know, like if, for example, if I would call their pet the wrong sex. So if I said, oh, you know, what did she do this weekend or something like that, she would say he. They would say, you know, they would correct me, very precise. Or if I would make a mistake grammatically, or if I would make a mistake about content or something, they would be very quick to correct. All right, some of the strengths in this population: IQ, grammar and vocabulary, rote memory, very strong. Remember things that most people would forget pretty quickly. Absorbing facts very easily, very interested in the social world, but also very aware that it's very difficult for them. I've had lots of females particularly say to me, I feel invisible. There's also just in the last 10-ish year been a lot of talk, particularly in females, although also in males, about how they camouflage based on their surroundings. So they're trying to fit in, even if it's not in their best interest to do so. And then also special talents, most of the time, because their areas of interest are so cognitively based, we can usually look at that as it applies to vocational skills, or at least really good rec leisure skills. Some of the challenges that this particular group face are pragmatics, so the social use of language, prosody, so like how their voice sounds, like the rhythmic qualities can be quite impacted, pedantic, so kind of routine or rote sounding language, difficulties understanding, expressing emotion, social and play weaknesses, kind of my way or the highway thinking, rigid thoughts, those kind of things, lacking in meaningful friendships, or having one friend and that friend has to be their friend. So there's some kind of rigidity along those ways as well. Idiosyncratic special interest, we just talked about that. Kind of did. So like I might have, like I have some kids that have idiosyncratic interests. So like spiders, but only like poisonous spiders, or life cycle of head lice, or things that are just kind of different, but then also impact their social relationships because they're quite different. Sensory differences, we talked about that already. And then motor clumsiness, both fine and gross motor skills. And these can be really impactful, thinking about gym challenges or PE challenges and how that impacts their emotional regulation and what that looks like in terms of their outward behaviors can be a really big area. Writing, really big challenge area, both in from thought, to output, but also from organization of writing as well. So writing is a pretty big area. Social understanding, difficulty with body language, may not use social niceties. These kids are frequently called rude or jerks, but it's not that they are meaning to be rude. And in fact, they're kind of appalled and really remorseful when they find out that other people have found they've been rude. And then that, of course, increases depression and anxiety about social situations. So we have to understand where the rudeness is coming from. And usually it's from an area of either misunderstanding or that kind of factual, analytical understanding. Well, she is fat, so I'm going to tell her, I'm going to say she's fat, or she has gained weight, or she's, she has said something ridiculous, so I'm going to tell her because everyone knows it's ridiculous. Why wouldn't I, right? They're also notoriously for stating the rules, but not following the rules. Okay, difficulties in understanding emotions, explaining their own behavior. They're really good at explaining the behavior of others and their own emotional state. And this is that interoception, and we haven't really talked about that, but knowing what my body thinks and feels inside and how that results in an emotion or a presentation of emotion. That's one of the sensory systems. So that all falls under that area as well. Predicting events and reactions of others to their behaviors. So knowing what's expected and knowing what's unexpected and how to change if you get yourself into a challenge area. Perspective and intention of others. They hold kind of all or none or black and white thinking. This is an old comic, but you always complain that I don't know how to show my emotions. So I made these signs. So, and I think maybe, I don't know. I think there might be a lot of people that would apply to, not just people with autism spectrum disorder. All right, language. These are some of the things that are in the criterion, but they're I'm kind of giving examples of them so you can kind of apply what you might be seeing in children that you either work with or have in your homes, but how that would apply back to the criterion is what I want you to be thinking now. And previous slides. Difficulty adequately conveying my own message. So, like how I sound provides information. So it's those paralinguistic cues, the prosody, the body language, the rhythm, the quality, like those vocal quality parameters. can be very difficult for individuals on the autism spectrum. Failure to seek clarification. So I call this the nod and smile. So like, oh yeah, I know exactly what you're talking about, right? But if you initiate that you don't know what a person is talking about, that puts you at a social difference, at a socially different level with people. So and it's an initiation challenge. So if I don't really understand something and I'm not really great at initiating anyway, or I'm really bad at initiating, it's one of my need areas. And I know that I'm really smart about other things, but or I don't care about your point of view, right? That's where that failure to seek clarification comes from. And then, just because I talk doesn't mean I understand is the next one. And then parroting back is that echolalia, either in an immediate echolalia, which we've already talked about. So, what's your dog's name? And the child says, dog's name, not answering the question, but echoing back what he's heard just in that 2 to 3 word format. So that is also an area of, that's also an indication. Whenever we hear higher rates of immediate echolalia, that's also an indication that our language level to the person is way too high, right? So asking a what question to a child may not be where their language level is receptively. Okay, even though they might say what doing or what's that, that doesn't mean they can answer those questions or receptively answer them. And then it also applies to delayed echolalia, like with the is your pizza in the freezer example that I gave before. But there's lots of these, scripting, so like repeating back lines of a movie, or you've heard it someplace, so it might be like the words, the introduction to a Pixar film or part of a commercial or something, and it's something that they've heard before. They may or may not use it appropriately, but it is definitely an echoed utterance or an echoic. Okay, flexibility. Difficulty typically dealing with change or unanticipated offense. But no one really likes change, like really like embraces it and loves it, but it's the response to those changes, all the way down to things like going a different route to get to grandma's house, or going past something that was previously frustrating, like a school or a church event, and they won't ever go by that church or school again. Their reaction may include listing the reasons why they can't engage in a new activity. That would be far too boring. I know that I'm going to get sweaty. Everyone there is going to be loud. No one likes me anyway. Those kinds of things might flatly just refuse to go along with things that are outside of their wheelhouse, or have had differences. And again, this is where that anxiety component comes in. And almost always it's a fear-based response to the situation. And a lot of times it just doesn't make sense, right? So, but we have to be knowing what is the flexibility level of the people that we're with, or are working with, or taking care of. Okay, so this is a quote from a very well-known individual with Asperger's syndrome, Lorna Wing. This was in Tony Atwood's book from 1998. Why don't we do what we mean? Why do we so often make trivial remarks that mean nothing at all? Like, wow, heck of a game last night, or you think it's going to snow today? Okay. Why do we get bored and impatient when someone with autism spectrum or Asperger's syndrome tells us hundreds of fascinating facts about arcane topics? Why do we care about social hierarchies? Why not treat everyone in the same way? Why are we so illogical compared to people with Asperger's syndrome or autism spectrum disorders? Okay, so now what? We're going to just quickly talk about some of the primary interventions. This is not a presentation on interventions. It's more of a presentation on characteristics. But I want you to be able to start thinking about what interventions would best fit, or best be a combination of fit, when you're thinking about characteristics of the people that you're working with, or for your own children. Okay, so things that are usually cognitively weaker areas, or areas of need: abstract thinking. And this, applies to, WH questions. It applies to areas of like more abstract language. It applies to figurative language. It applies to organization. So kind of abstract concepts of time as it applies to long-term planning. Okay, things that are auditory only, and there's very few of these, particularly for the young child, but typically individuals with autism spectrum disorder have more challenge with auditory information as opposed to visual information. So if you know who Temple Grandin is, she's a very famous or popular person who has an autism spectrum disorder, has her doctorate in animal sciences and animal husbandry, and she has autism. She's a classic presentation of autism as a young child, and she now has her PhD, like I said, and she will say, I think in pictures, and my brain is like a website clicking through the images, one links to the other. And in order to have language linked to those, I have to click through the visual process of what I know about that topic in order to have auditory or verbal output about that, that topic or concept. Okay, so weaker areas, abstract auditory reasoning. So you remember we talked about kind of inflexibility, difficulty with black and white thinking. So reasoning skills and being able to know the thoughts of others and perspective of others is going to be really difficult for a person on the autism spectrum. Imitation, I'm going to add initiation there as well, and then also generalization. Learning an activity or a task or whatever in one setting does not necessarily mean that they'll be able to do that task or skill in another setting. Okay, some stronger areas, things that we need to use for intervention are things that are concrete, strategies or thoughts, activities that are visual based. So remember mechanical information, being able to look at imagery and understand like the hierarchy of the imagery. So if you think about like architecture, the different periods of architecture are very visually clear. And so that might very well be an area of interest, okay? Or maybe even a vocational calling. Things that are perceptual, things that are gestalt. So like being able to see the whole picture. And then memory is also a strength area. So all interventions need to generate predictability, usually in a visual or written or picture-based way, be communication-based so that what we're asking of the individual is in a way that they understand. So probably not just verbally, right? So I can't tell you how many times other people have said to me, and I've said to myself, but I told him that, right? I told him we're going to grandma's first and then the gas station or whatever. Well, that's not a strength area. So we have to be able to demonstrate it visually, right? And it's also not a strength area for the individual because it's an executive functioning difference. Okay, using visual spatial modes of presentation. So I can see it and these are how the elements go together. Not be dependent on spoken language, not that we're not using spoken language, but we have to be augmenting it, particularly for task demands or activities that we're expecting them to follow through on. Be built around some of the child's interests or even fascinations. So teaching math or teaching language, we can do, or not teaching language, teaching math, teaching spelling, we could do, like 2 traditional spelling words or, whatever the second grade, second week list is, but then also throw in something like, how do you spell larva if they're into the life cycle of head lice? So we're building in interest areas, but also getting at the task demand. Have functional relevance based on assessment. I cannot tell you how important this one is, particularly when it comes to communication and daily living skills. There has to be a functional reason for the individual to learn a task, and it has to be based off of assessment. When we don't do these 2 things, that's when we see an increase or a spike in behavior. Okay. And then the intervention also needs to result in errorless learning based on principles of reinforcement. Okay, so think about how you learned a task. Okay, so think about maybe driving or learning your math facts or whatever. You had to learn some of these things errorlessly, and then you're reinforced for doing them. But we kind of self-impose those levels of reinforcement. For a child on the autism spectrum, and I would argue anybody, right? Finding those areas of reinforcement and using them so we don't have to clean up mistakes is a much more efficient strategy for the child with autism. They have a very small amount of time to learn a very large amount of skills: social communication and emotional regulation and sensory regulation, that come very easily to most neurotypic individuals. So we want to be able to teach it in a way that doesn't teach error patterns, and also teaches them that when I work harder, I get better reinforcement, which is what most people do anyway. So we just have to teach them that. Okay, I do like talking about this intervention ziggurat because I think people start here at skills to teach when really they should be starting here: sensory differences and biologic needs. So this little bumpy-sided pyramid is a ziggurat. And the intervention ziggurat facilitates the development of targeted positive intervention by looking at the base level being sensory differences and biological needs. Whenever I talk about this, I think about, this was years and years ago, maybe even in the mid 70s to early 80s, there was a Fruit of the Loom, yeah, that Fruit of, it didn't sound right. Fruit of the Loom commercial for underwear that said, its tagline was, "It's hard to think when your underwear are too tight." Right? So if we don't attend to this sensory and biologic level, we won't be able to attend to reinforcement, structure and visual tactile supports, task demand, and skills to teach. And where do we start when we're talking about Common Core, right? Or where do we start when we're talking about taking a bath or brushing teeth or whatever? We're like, I'm going to start right here. He's got to brush his teeth, so let's brush his teeth. But what if we don't know the steps for brushing teeth? What if the sensory biologic level makes us gag on the sight of a toothbrush being put into our mouth with toothpaste on it? Ugh, right? All right. So this is the levels, and you're going to have to zoom in on this baby, but some examples are in there. We're right at that hour level now, so I'm going to just kind of zoom through this a little bit. These are some of the sensory and motor differences that we've talked about already, but we haven't talked about as much hunger, pain, illness, and sleep. So one of the things that I get called into all the time are significant challenging behaviors when the function is a sensory biologic need. It could be too loud, it could be there are too many noises, it could be that they're not eating because their medication is suppressing their appetite. It could be that the task demand is outside of their muscle, their gross and or fine motor skill set. And so go back to that bottom level of the ziggurat and start there when you're looking at interventions. Modifying the environment to ensure physical health and comfort results in or can result in a more successful intervention program. Reinforcement is, doing best work for best best reinforcement or best consequence for ourselves. So reinforcement as defined reinforcement defined is a situation or event that follows a behavior and results in an increased likelihood that that behavior will reoccur in the future. That means that situation or event is the reinforcement for that behavior occurring again. And of course, we want that behavior to be effective or functional for that individual. Provided that a consequence is desirable, the behavior will be displayed more in the future. So that's why we don't want to reinforce when the behavior isn't what we want. And as parents, that's what we do all the time, right? So you're on the phone and you're talking to your sister or whatever, and your child comes up and taps you on the leg, and you say, no, right, real quietly. And you keep talking, and it's, 30 seconds, 45 seconds, however long it is. And then the child, takes your, leg or shirt or dress or whatever and bangs on you and says, Mom, right? And then you say, not now, I'm on the phone. Go play with your sister or whatever. So you've given them reinforcement for behavior that you don't want, and it's negative reinforcement because you're trying to redirect them to something else, but you've just increased the likelihood that they're going to ask again. Okay. So the use of reinforcement has to be for the behavior that you want to have them continue versus the behavior that you don't want to see again, or hopefully not reinforce. Hope that makes sense. Okay, the next level is structure and visual tactile support. This is where structured teaching comes in. This is where use of visuals. This is where auditory is the weaker cognitive area. Visual tactile is the stronger cognitive area. So it's based on the core characteristics of autism spectrum disorder. There's an intense drive to find order and make sense of their world, and they tend to conceptualize and experience activities or events in a visual way. So we have to use visual information in a variety of ways in order to teach and improve communication skills. Next level is task demand. So this basically means removing obstacles so that the child can access what they're supposed to be accessing. So is it appropriate to expect John to be able to sit in a classroom for 45 minutes? Okay. Or what are the social demands for Maria at work? Or can Marty copy information from the board? So look down, back and forth, back and forth. Does Miguel have the skills to handle a field trip to the art museum? So we're going to remove the obstacles for those situations so that the expectations can be better met. Last one, which is, like I said already, is where most teachers, if that's a parent or an educator or a doctor or whatever, this is where we typically start. So we make our goals and our objectives with very little attention to the other four areas. Okay, autism spectrum disorders are lifelong and a lifelong condition that require intervention throughout the lifespan. Only when the sensory system is calm, reinforcement is available, the environment is made predictable through structure and visual tactile supports, and task demands are carefully designed, can skills be effectively taught or demonstrated. So there's a lot of work that we have to do before we get to the ability to meet our goals and objectives. All right. I'm going to just kind of pop through this because you can look at that on your own. Spend a little bit of time on structured teaching. So this is that third level of the intervention ziggurat. So use of visual supports. This is where things like schedule, work system, visually clear and organized instruction comes into play. It's a whole training into itself. The Center for Disabilities does two great trainings on this during the summer. If you're interested, I would contact them. Or you can go to teach.com. It's 2 C's. That's true, TEACCH.com. And take a quicker or a better look at this. But it's basically making, helping make visual sense of what it is that we're requiring or wanting of the individual. So looking at that third level as it applies to that top level of skills to teach. This is a really easy, I don't know, can I like click on it? Oh, hot diggity, I can. Let's see if it works. I don't know if you can see it or not, but oh shoot, it's not, it's a faulty link. All right, so forget that. I'll fix that. If you just Google work baskets and autism classrooms, something else will come up. It's basically a website that gives you different work basket or work task activities, so you don't have to use your brain as much. Let other people's creativity work for you. Okay, so what should you be considering? What should be in your autism spectrum disorder toolbox? Understanding the characteristics of the individual or individuals you're working with and how does that impact their world? How do they best learn? How do they best receive? How do they best give information? What are they doing from a communicative perspective? What are their sensory needs? Those things. Know about structured teaching, know its value to you as a teacher. Okay. Applied behavioral analysis. We haven't talked about that, but that's a big part of intervention. And we talked about reinforcement. That's one of the hallmarks of applied behavioral analysis. What is typical for play and social emotional skills? What should we be expecting our individuals to do? And what are they looking like at a developmental level? What are their emotional regulation skills? And how can we help teach replacement behaviors for those behaviors that we don't want to reinforce? Zones of regulation is a really great way to look at that. Also, the incredible 5-point scale is a great way to look at that. Social thinking. So when we look at executive functioning, when we look at knowing what other people are, other people's thoughts, feelings, and ideas are, I would add in their executive functioning in terms of being able to use time and understanding the process of time and sequencing. Sensory processing and how that presents for your individual learner, because what it looks like on the outside might be, like screaming, but really what it means is there's something happening auditorily that's making them really frustrated. Writing and written expression, we've talked about that too. Okay, so from an education standpoint, people who have autism spectrum disorders may be eligible for an individual educational plan, an IEP. They may not be eligible and or in need of an IEP. Some of those individuals may have a 504 accommodation plan, so not a teaching plan, but an accommodating of the environment plan. There has to be a balance between how we, the demands we place and how we look at reinforcement. There has to be a balance for the individual to continue to see forward progress. It's almost always a team. I can't think of a time when it hasn't been a team. And then also mutual respect between all of the disciplines. And by that, I mean the parents, the grandparents, the OT, the educator, the special educator, the administration. There has to be mutual respect for the best outcome for the individual. And that can be quite difficult. So always wear your kindness hats. Holding regular meetings, looking at progress regularly. Every 9 weeks is not enough typically for the individuals that I work with. If inclusion is the goal, which of course we would like it to be, or whenever a student is in an inclusionary setting, then there has to be an increased rate of communication between special education and general education staff. And of course, I'm talking about a school setting right now. And of course, there should always be communication with parents about homeschool, but also generalization, because we know kids with autism do not generalize well. So it's imperative that people are talking to each other. Decide what's clear, what needs to be modified or altered, make those modifications, work towards communication, functional communication and replacement behaviors as it applies to challenging behaviors, and then restructuring, which applies right back to regular meetings and communication. Some websites for some good additional information and my contact information. So that was autism characteristics in a very quick fashion. So if there are questions or concerns, please do not hesitate to give me a call. Thank you so much.